All right, good evening. It's Respiratory 129. It's week 4. It's October 23rd. And Tim Dunkle here, your instructor. Welcome to week 4. Thank you, everyone, for a great mod and all your hard work and everything you've done to make it happen and to get through this step to the end result of graduating and taking your TMC exam. It's been a pleasure working with you. We've got some stuff to chat about tonight for you. Maybe we'll even show you some more stuff. Apologize for the whole camera part. If I could just show the stuff without me in the way, I need to figure out how to do that better. Anyway, so this week you have your physician interaction form to submit, your second one. You have your hours to submit, your clinical hours, and then your PCE form. All that's got to be in, and it has to be in before Saturday, because they are on me to get grades turned in as soon as I can after that mod closes. And so all that has to be into me before I get those grades submitted. So please start working on it sooner than later, like right now if you haven't, and get going on that and make sure those are all filled out and submitted. And make sure before you submit it up into Canvas that all those signatures are present. So remember, there's 3 signatures that need to be there. Your signature, your preceptor signature, and then your signature from Annalise. And she has all the access to DocuSign, so she can look at your preceptor's signature and make sure that the name and the signature both jive up and are accurate. And then her signature says to me that it's been approved, and then I can grade it. So that's the process. Make sure you have all your signatures present when you do that, and we will make it happen for you. So get that end of it done. Make sure you get your discussions done also, and get that all in, and make sure you're not late on that, and you'll be good to go. Remember, you also have your daily questions, and make sure you're doing those as well for this final week and getting the low-hanging fruit, those easy points to get. So if you have any issues with any of that, please get a hold of me, and let's do this sooner on the front end of the week, not on the tail end of the week when everybody's stressed because their preceptor's gone out of town and things like that. So communication is the name of the game to get that stuff in. So make sure you're communicating with your preceptor and get in touch with me ASAP if you're having any issues. For your future's bright. As you finish up through this program, your goal should always be, and keep in mind, and I can't say it enough, that your TMC exam is your #1 goal. You can go through this program and you can end up with a degree, but it doesn't mean a whole lot out there in this world if you don't ever pass your TMC exam. You're never going to work the business. You got to have that to get your license. And as I said in week 1, other states are already rolling on that do have in place that you need to be an RRT to get your license in those states. And if a few states have started it, I think that you're going to see that trend continue across the nation. And so your goal should be to pass that TMC exam at the high cut score so you can get your RRT, and at that point you'll be able to license anywhere in the nation. You'll be good to go. So make sure that happens. The TMC exam is hard. I'm not going to candy code it for you. but it's doable. And if you will pay attention in your classes and work hard, and at the end, your SIE practice exam and the review course that the IU will provide you, if you'll do all of that, you're going to do great. You'll do fine. But it's hard. It's a hard test, but you can do it, and you'll be prepared for it with some work on your part, and you'll make it happen, and then you can work in the business that I so love. It is Respiratory Care Week this week, so I wish a happy Respiratory Care Week to all of you. And it's always a nice week for us at the facility, because we usually get vendors or the facility will buy us lunch. And, you know, who doesn't like free lunch? So that's one benefit of Respiratory Care Week. But it's our week, and usually the hospital says something or does something nice for us as well. So happy Respiratory Care Week to everybody, and remember, that's always like the third week of October is typically when it is every year. Let's see what else we want to talk about. Your licensure we've kind of touched on. If you guys have any questions, let me know. Like I say, let's take care of any issues with DocuSign on the front end of the week. Not when it's Saturday night at 11 o'clock and you're stressing out because your preceptor hasn't got back to you. Communication is the name of the game, so make sure you're communicating with them, letting them know, hey, it's coming down the line, and if they have any questions or issues, we've got resources to help you and help them. But business hours is the best time to do that. Annalise isn't like me. She works in the office and isn't going to be super and things like that like I am. So if we need to get her involved, let's do it weekdays during business hours. So keep that in mind. And like I say, I've said it before, but if you need anything, let me know. I want to be a help to all of you, not only for this mod, but through the rest of your IU experience. And when you get into the business, if you have a question or you see some or need a contact or whatever, I'm in this business for this profession, I should say. I'm in this profession to help you all, and I want to be a resource for you if you need it. So feel free to contact me even outside the mod. And you guys have my number and email, and if I can do something for you, I will use whatever resources I have to help you out and help you with questions or needs or whatever. And I know that the faculty at IU that there's some really great folks, and everybody's really devoted to making sure that you all are successful. So with that, let's jump into what we're going to talk about for our final week. Keep in mind that kind of the reason that I show you all this stuff is as you're kind of new into your clinicals, and you need an opportunity to generate some discussion and maybe some devices you haven't seen. And so as you recall, we kind of started with flow delivery at the start of the mod, talked about oxygen delivery, and then last week we talked about humidity. And this week we're going to talk about aerosolized medication delivery and some of the stuff that entails. So without further ado, we'll jump into that. You'll have an opportunity to study respiratory pharmacology if you haven't done so yet. And there's a plethora of meds, and there's lots of devices out there, all with the same goal that we need to get aerosolized medication to the airway to do what it's targeted to do, whether it's for inflammation, bronchodilation, pulmonary dilatation of the pulmonary artery, all those things that we can do with aerosolized meds, but we want to do it right, and we want to get the maximum amount of medication to our patients. So I'll show you some devices tonight that'll help you to facilitate that. And to do that properly, and also we'll talk about interfacing aerosolized devices onto ventilators and things of that nature. So I've got some pictures, and if we decide to, I can fire up the camera and show you some stuff as well. And I'll probably show you just a couple of tricks how to get medication to folks and things of that nature. So we'll just see where we go tonight. If you have any questions when you watch this, if you're not live, feel free to shoot me an email and we can talk about it too. But also, I hopefully it'll generate some discussion between you and your preceptor or your mentor, whoever you're doing your rounds with, your clinical time. And that's my greatest hope with part of doing this, is that this just gives you a talking point with your folks in the hospital, and they can take you down to the equipment room. And I've been in a lot of hospitals across this great land of ours, either working air transport or I was a clinical rep for a pulse ox company, and so I've seen a lot of hospitals from one end of this nation to the other, and every respiratory department has their little dark closet or room where they keep all their little fittings and all their stuff that only respiratory therapists understand. And that's part of the fun of the job, is building stuff up and making stuff work. I think about the days when we used to make heated BiPAP circuits out of hood circuits to provide better humidity to our patients before the big manufacturers even made that sort of thing. So there's stuff you can put together and work on and make it happen for your patients. So I tried to think of the meds out there, or that I've nebulized to patients before, and this list is what I've nebulized to patients. And there's probably some outliers, and there's some chromolant sodium and some of the older stuff that we don't use as much anymore. But this is kind of a list of stuff that I've nebulized to human beings before in my career. So we have normal saline, albuterol, Atrovent. You'll do a lot of that. Racemic epinephrine for your Kruper crowd. Your ANA or your SABAs or short-acting broncho adrenics, or Brovana is your LABA, which is your long-acting bronchodilators. Performist is also a LABA. Pulmicort and Decadron, both steroids. Working on the inflammation portion of when we're dealing with asthmatic or spasming airways or inflamed airways. Morphine, once in a while we'll nebulize that to our folks. Tobramycin, short for tobramycin. That's a antibiotic that we can nebulize, and we'll do that in CF folks and folks of that nature. Mucomyst and Dornase alpha are mucolytics. Interestingly enough, the AERC, or the American Association of Respiratory Care, which is kind of our governing body, kind of our association, they issued a paper on mucomyst, or a statement on mucomyst, that they don't see any effective respiratory use for mucomyst. That perhaps there's not enough sufficient data to show that it does anything as a mucolytic. We also give mucil mist. It's a trade name, and it's the other name it has is acetylcysteine. We give it to folks that have overdosed on acetaminophen. Is what's that really is given is IV for acetaminophen OD. So anyway, Dornase alpha, kind of specific to the cystic fibrosis crowd. And so anybody, times we have that crowd or that patient with us, they're typically going to be getting the regimen of the pulmozyme or Dornase alpha, whatever you want to call it, with the hypertonic saline. And then they also usually have a bronchodilator on top of that when we give that to our patients. Calcium gluconate. Patients that have inhaled acid, we'll give them calcium gluconate, and I've given that to inhaled injured airways that have inhaled acid. Either it's industrial or whatever was going on. Lidocaine, kind of numb up the airway before we provide a bronchoscopy, things like that. Xopenex, we don't use a lot of Xopenex in our facility. It is a SABA, short-acting bronchodilator. And when that first came out, their big thing was that it was more specific to the beta-2 receptor and that it didn't cause as many cardiac effects. Their sample size was really small, and I kind of ticked off the rep when he first came around. This is probably 10 plus years ago when they were really starting to push Xopenex because it was new to the market. And he showed us that the data on the study that showed that it didn't have as big a cardiac effects. Well, the N, or the group size, was 27 people. And me and my big mouth, as I'm eating the lunch he brought us, says, well, that's not very big. How can you draw any conclusion from that? Which I offended him. But anyway, the hospital system I work for, they don't even have Xopenex on the formulary. It costs more. And we didn't see, when we did meta-analysis over several years of using this in the hospital system that I worked for, there wasn't a statistical difference in Xopenex and albuterol with helping the heart rate stay controlled. And so it was eliminated from our formulary because it costs about 4 times more than albuterol. So in my hospital system I work in, we don't even use Xopenex. Next up, surfactant. So typically surfactant is administered, you intubate the child, and you put the patient on one side, you put a surfactant catheter down, and you administer 3 cc's per kilo of surfactant. We use Infosurf in my facility in our NICU. And you inject that into the lung, and then you withdraw and allow them to sit there for a minute, and then you bring them back to midline, and then you roll them up on the other side and repeat. And that's how we've always given surfactant, is inject it right into the lung. We're doing a study now where we're nebulizing surfactant via a special high pressure nebulization device that comes out of a binky as it sits in the baby's mouth. And so, yeah, I've nebulized surfactant now. And so that's a new thing, and that's been kind of fun to participate with this study, and it's a phase 3 trial. The guys like me that like to intubate, if this trial takes off and they get FDA approval, we might not be intubating kids as much, which, you know, in the end result is good. There's lots of potential complications from intubating, so if we can just nebulize that surfactant at them, it's going to be better for the kid. There's certainly kids that still need to be intubated, and we'll surf them and keep them on the vent. And that's certainly that micropreemie crowd that will never, I don't ever see us trying to nebulize surfactant to that crowd, just because usually they're pooping out and their work of breathing so great, and they're too young and those lungs are too underdeveloped, but maybe we'll see. Flolan, Ventavis, those are dilators for the pulmonary artery for pulmonary hypertension. not only the pulmonary artery, but the pulmonary vasculature. And so these are potent bronchodilators, or excuse me, dilators that dilate open pulmonary vasculature. And so I've had an opportunity to administer those through their specific devices to patients as well. So I was just thinking I put normal saline, I didn't put hypertonic saline, so we've done that as well. Anyway, that's the stuff I've nebbed. So there's lots of different ways lots of meds to do it. And some of those are really specific on how to nebulize it. So we'll keep it basic and just show you some of the basic equipment to provide treatments. And here's the basic of basics. It's just a small volume nebulizer. By the end of your career, I think it'll be tough to count on how many times you've assembled and loaded these to your patient. They're about $1 a piece. We flow based on whatever the manufacturer suggests, but usually 6 to 8 liters per minute of flow through these. And the 0.4 micron particle size is the kind of our target we want to get optimal lung deposition down in the distal airways and the areas we need to get it to down the tracheobronchial tree to deposit in there to dilate, open those airways or whatever we're trying to accomplish, so that our airway resistance goes down and the patient can breathe easier. So SVN or small volume nebulizer, when package, it's typically disassembled. Some of you might think, gee whiz, why is he going over this? I will tell you, I had a student not too long ago who had been doing it, was an IU student, and I thought he'd been through a couple of mods of stuff, and we went down to the ER and had a treatment. I handed him the bag and I said, go ahead and get it going. He's like, I've never put one of these together. I was like, oh goodness. So here we go. We're going to turn on the camera. Apologize. Okay. So so here's our little setup, and this is how it's going to come, is like such. And so to assemble this, we're just going to pop that there, pop this here, that there, and then your hose hooks in like that. Okay. One little trick that I like to do is this piece here is a reservoir. So when the patient's sucking in, they're going to draw out of this chamber here, and then they're going to pull this medication out of here as well. So when they're exhaling, this fills up with medication, so it just allows them to get that much more medication with each breath. So that's why that corrugated tubing's here. That's probably one of the most common questions I get. But here's a trick for you for a pediatric patient. So most peds aren't going to be able to use the mouthpiece, and good luck trying to get a mask on them. So what you can do is take a piece of plastic from your bag, pop that over the mouthpiece, and now you have the medication all flowing out of this. And if we have a kid diving and ducking and crying and trying to hide, you know, I can chase that kid around and get the med to him, especially this season. You know, the other night I covered a night shift, and I think we had 6 croupers that night that we took care of, and so we just blew this racemic epinephrine into our patient's face and let them breathe that in, and that's great for the crewper crowd. Then the other thing, since we're live, I'll just do this is we do have the aerosol mask, and so you'll ditch your mouthpiece setup and pop that into your aerosol mask like that, and then you can provide the aerosolized treatments to your patients that way. So we'll get rid of the camera so you don't have to look at my ugly mug the whole time. So that is down and dirty, the SVN. That's the cheapest way to provide that, and most facilities stock those by the bushel. I know that certainly this time of year we've brought in extra just because we're starting into winter in the busy season, and over the course of a shift we'll go through lots and lots of these nebulizers, and they're usually pretty cheap to provide to our patients as well. And so that's the other. So we had a question, I just caught it in the chat, and there's a question about nebulized morphine. The reason that we nebulize morphine is really, really awesome as an analgesic for pain control, but it's really great for air hunger. So we have patients that perhaps don't have IV access or things of that nature. You can nebulize morphine at them and they still get those effects. And the nice thing is when people are dying and they're in palliative care, you'll see them in air hunger and gasping, and one, they're not comfortable if they're still coherent, but two, the family sees that, and it's usually quite upsetting to them. And we do a lot of education, talk to them, but we can nebulize morphine if we don't have decent access, and help provide them with some of that air hunger issue of palliative care. So that's why you might on occasion nebulize morphine to your patients. But you know, the 15 years I've been in the business, I can count on one hand how many times I've done it. But that's usually why, is they don't have good IV access, and they don't want to give them a shot or poke them, and the family's frustrated, or not frustrated, they're just concerned. They don't want that for their loved one. And so we'll roll in and nebulize some morphine at them to let them have that effect of that med to make them comfortable. So there's our SVN with our face mask and our aerosol mask, and so that's what that looks like. And when I provide treatments to my patients, what I usually do is I put an aerosol mask in my back pocket, and I go in and I show them the mouthpiece, and I ask them if they've had a treatment before. And a lot of them are like, yeah, you know, or, you know, a lot of these patients I already know. And I'll ask them, you know, do you like the mouthpiece or the face mask, or what do you prefer? And I'll give them the option. And the ones that know what they like, they're going to tell you. And the ones that are going to say, I don't know. So I'll pull the face mask out of my back pocket and just show them, and this is what it looks like, and tell them why they might like the face mask. And some, you know, are claustrophobic, they don't want the mask. Others like it because you can pop it on them and they can keep sleeping or whatever they're doing, don't have to hold it. And so folks really really like that setup as well. And since we're showing tricks tonight from Respiratory World, so if you have a patient, you know, typically your nebulizer needs to be straight up and down, as you can see in that picture, and so that it that the medication properly nebulizes. If it's on its side or upside down or whatever, you're not going to get any benefit from that. So let's say you have a patient that's sleeping, they're laying back or not at an optimal angle where you're getting a lot of nebulization, and the nebulizer will be on its side if you have the patient laying on their back. So here you can attach your block off this end with your bag and then attach this to that. So if the patient's laying down on their back, you're still keeping your nebulization chamber perpendicular to the ground. And then they can still lay on their back and stay asleep. And you're still optimizing your position where you're going to get nebulization from the device. So another trick of the trade that I'm sure you've probably been shown in your clinical course or your clinical time. But if not, there's your chance to see that. So there's another device out there, and it's called a band. So SVN is a small volume nebulizer. The band is a breath actuated nebulizer. And so how this device works, and I'll do a little drawing here. So how this device works is, of course, we've got our mouthpiece there. Here's our supply there. This is our reservoir for our meds. We're going to pop our med in there. And what happens is there's a spring in here. And when the patient sucks in, it causes a negative pressure, and this whole system, whoop, let me clear this out. This this deflects down here, and what it does is allow the gas to, excuse me, what am I doing here? Deflects this way. And this opens up, and this opens up a valve and allows the gas to flow into this chamber and nebulize as we're used to. And so the patient sucks the medication up and out of this chamber to them. And then when they let off or stop sucking in, then the valve closes this back off and the device turns off. So the only time you're getting medication out of this device is when you're sucking in. So what we'll do is we'll put concentrated medication. We won't dilute it like we do with the SVN. And then they can take 6 or so breaths, or we'll even have them take breaths to effect where they stop breathing, and then they're done. So the nice thing about that is most nebulizers run anywhere from 5 to 10 minutes based on what you got in there and how much flow you're putting through it. With this device, they come in, you load it up, and they take, 10 breaths off it, and they're done. And so the nice thing about this device is it's a time saver for us. It's a time saver for the patient. It doesn't take forever. And they get still good medication deposition to their lungs. And so it works pretty good. There's some facilities that use them. We have them in our facility just in case. The problem is they cost quite a bit more. If you're a little kid and can't put your mouth on here, that's not going to work. If you're a patient that is asleep, you have to wake up and do this. Sometimes they get frustrated. They'd rather just wear a mask and sleep through your treatment in the middle of the night. So there's kind of a specific patient population that likes these or will use these. So keep that in mind. And like I say, they cost a little more, than they have a few more working parts in there. So they're around out there. Ask your clinical site if they carry them, and see if you can pull one off the shelf and look at it. But they do serve a pretty specific purpose, but that purpose is good, and it can be a time saver for you, especially when you're having one of those mornings where you've got 15 treatments to do, and your patient in the unit crumps, and now you're behind for the rest of the morning. You're trying to get everything done before second round starts. So that's where these are nice, and you can save a lot of time. So on the recent, last 5 or so years, these have really come more into play. This particular brand's AeroNeb, But this is an ultrasonic nebulizer. Now instead of using compressed medical gas, whether it's air or oxygen, to flow up and through that tight port to increase in velocity and to break up that medication. Now we have a device that uses ultrasonic waves, and how this does this is this is the control module. It plugs in the wall, but it also has an onboard battery, and you press the on-off button here, and you can either set it for continuous. Some of them are for 15-minute and for 30-minute nebulization times. The ones that we use now, our newer ones, are 30-minute and continuous because we're starting to use these for continuous nebs for like asthmatics. So this provides a electrical current up to, there's a disc in here. So you dump the medication in right here, and that electrical current hits that disc, and it vibrates at thousands and really high frequency, hundreds of hertz, and it vibrates at such a high frequency that it breaks up that medication, and that medication drops in this chamber. And you can either put a mouthpiece out on this end, or a mask, or you can hook this in line to a ventilator circuit. And so you can interface this the same way you would an SVN to your patients. The downside is these are expensive, and it requires parts, and these are all throwaway these days. We used to reprocess these interfaces, but now everything's disposable, and it's clear plastic instead of opaque like this. And so it costs a little more, but the nice thing is when you use these on ventilators and things like that, you don't introduce additional flow into the vent circuit, and so you don't have triggering issues, you don't have peak airway issues, you don't have high volume alarm issues on your vents, and on your BiPAPs. You don't have triggering issues because you're adding additional flow. And these vents and BiPAPs, if you start adding additional flow from a nebulizer, 6 to 8 liters, it didn't deliver that, but it sees all this extra flow coming down, so it starts alarming. Or if you're in a closed system, it increases your peak airway pressure. So you have to turn down your tidal volume and make adjustments to your vent so you don't have high peak airway pressures. The nice thing about these is that it doesn't inject any flow in. It's using those ultrasonic waves to break it up, not flow. And so you don't have that issue with these. So in the facility that I work at currently, we like these, and we use these on all of our vents and most of our BiPAPs for that reason. That's not adding flow into the equation or into the circuit. That's really nice. We used to not have this option until these came out. But like I say, they're an increased cost, so some facilities aren't crazy about paying for them or buying them. The other nice thing about these is like as I mentioned earlier, is you can put these into continuous mode. And so what we do nowadays for continuous nebulization is we'll load up a syringe based off the cc's or the milligrams per hour of medication that the physician's ordered for continuous nebulization, and we'll load up that concentration into a 60 cc syringe through IV tubing into one of these chambers, and you put it on a syringe pump, on an IV pump, and it pumps the nebulization rate into this chamber, and you give a really precise continuous nebulized treatment to your status asthmatic patient. And we really love them for that. Also for the drug I was telling you about earlier, Flolan, which is a pulmonary vasodilator we use it for the same purpose. And so we give this continuous medication that's never interrupted. It's a precise dose, and this nebulizes at a precise rate. And so everything's done at really nice calculated rates and doses. And so we can optimize our medication delivery to these patients that are really sick patients. And so that's how we're doing things nowadays. Whereas we used to use this particular device, and this is called a mini heart continuous nebulized device. And how this device works is it comes with a piece of paper, and I need to take a picture, or find a picture online of the piece of paper. But what you do is it says, okay, the physician's ordered, 8 milligrams an hour of albuterol to this patient that he wants with continuous nebulized treatments. So what you're going to do is you look at the paper and it says, okay, put this much albuterol in it to this line. Whoop, let me put it in the drawing mode. So put so much albuterol to this line, and then put the rest saline to this line, and that'll give you 8 milligrams per hour at this much flow. And so here you put your oxygen hose or your oxygen supply tube coming in right there, and then you have that same respiratory fitting on top. And typically for continuous treatment, we always put them on a mask so they don't have to sit and hold it there for 1, 2, 3 hours or how long it's going to run. And so this just hangs down below, and we provide the treatment there. So that gas comes in at a high velocity, creates that Venturi effect, so we have negative pressure. That draws the medication up this tube, and it expels out that nebulized medication, or that broken up fluid, and then the patient sucks it in. And so the nice thing about these is you can set them up really quick. They're really quite inexpensive to do them, and they work good. They're a good backup. So we like these for what they are, that they're quick, they're inexpensive, but the precision of this and how it doesn't inject flow if you're running on BiPAP or Heliox or whatever you're doing, or on the vent, versus this one. This adds a bunch of flow to the system and can mess with your machine. So we like these, and anytime I'm running one of these, I've got one of these sitting right next to it, because it's a good backup device if we need it. But we like the precision and how uniform the particulates that these provide for those sick patients. So we've talked a little bit about placing these treatments in line of the ventilator or BiPAP. And the best tool to do that, to make that interface, especially on things like a ventilator where we don't want to ever break the circuit, because we know that breaking the circuit causes ventilator-acquired pneumonias. So we have this little device right here. And I'm trying to think if I have a better picture. I think my next one's a little better picture of that. But here we have this device. It's called a valve T. And there's a spring right here. So you press your nebulizer up into there, and it lifts up a little hatch or a little covering in the tube, and it allows the nebulized gas to come out like this. And then when you're done, you just pull this out, and that valve, this closes back off and lays across there and seals off the circuit again. So the nice thing about that is before we had these, we had to literally open up the circuit, put a regular T that came in the nebulizer, and give them their treatment, and then break it back open and take it back out. And now we learn that we're potentially causing ventilator-acquired pneumonias in these patient populations because we were opening up the circuit all the time. and this prevents that. And it's got a little cap that covers that hole where you stick your nebulizer in between treatments so you don't get any debris or anything up in there. And it's a nice way, slick, quick way to do that, especially if you're at a facility that perhaps doesn't have a aero neb, and this is how you provide those treatments. Or you just need to throw something quick in line and you haven't got your aero neb fired up yet to provide that. So here's a picture of what it looks like in line going to an ET tube. And just keep in mind that when you're providing these particular treatments, that you put it on the right limb. Remember that we have an inspiratory limb and an expiratory limb of the ventilator circuit, and certainly you want to put this in the limb of the circuit that's the inspiratory limb. If we put it on the expiratory limb, it's never going to get to the patient, and all that medication is going to go to your expiratory filter and gum it up and fill it up, and you're going to have high airway resistance and peak airway issue problems, and it's not because of the patient, it's because your expiratory filter's gummed up. So that's something to think about. And we want to put this on that expiratory side so that that medication flows to the patient. So some inline considerations you want to consider, and this will make more sense as you get into your ventilator courses. But there's two different ways to for the patient to tell the vent that they want a breath. They can either displace or suck in, and that creates a negative pressure there, and the vent detects that negative pressure and says, oh, the patient wants a breath. The other way it can do it is it can flow some continuous flow at a low level throughout the cycle, which is called flow trigger, and it puts that known flow through it, and if the patient sucks in a certain percentage of that flow, then the ventilator says, oh, they want to take a breath because I'm not seeing that flow come back to me. The reason you want to consider which trigger type you're in, whether it's in trigger or flow, that affects where you're going to put your inline T. So this one you can see is out here close by the patient Y. Here's the ET tube right here that's going to our patient, you know. So that goes to our patient. And so as the gas flows in here, we're almost to our patient. So if it's in pressure trigger, patient trigger is triggering pressure, the pressure is static in the circuit. So all this medication kind of sits and settles right in this area. And that's fine, because once they take that breath, then all that medication that's kind of settled in here in between breaths goes right to the patient. So all this tubing in this general area acts as a reservoir, and the patient gets all that medication there. If this is sitting this close to the Y, and we're not in pressure trigger, but we're in flow trigger, remember I told you there's that background flow that's always flowing through the circuit. So all this medication is flowing that way in between breaths. So that means that the patient doesn't get a whole lot of medication when they suck in. They don't get a lot of medication that they need. So what we do in this situation, if we're going to keep it in flow triggering, what we're going to do is we're going to take this T and we're going to put it clear down here. We'll put our T clear down here. I'm just adding to my picture here. And the reason we'll do that is that flow is trucking through this circuit. It fills up this whole inspiratory limb with medications. So yeah, some of it's going to escape this way, but when that patient takes a breath, now it gets all of that medication to the patient. So we've created a longer reservoir there. So that's a trick of the trade when we're doing inline treatments, to make sure that we pay attention to what our trigger type is, and based off that, and then we can put that in the optimal spot to get the most medication to our patient. So hopefully that'll be a a lesson for you when you start working with vents and are giving treatments to patients. Pay attention to that in your clinical time, and ask your RT what the optimal position is based off their trigger type on the ventilator or on the BiPAP. If it's on the BiPAP, um, most of the BiPAPs out there, we use the Philips or the Vision brand, the Philips V60 or the Respironics Vision, which is owned by Philips, and that has a whisper valve. And if we put the treatment before that whisper valve, a lot of that medication just goes out in the atmosphere through the whisper valve. So we want to put that treatment past the whisper valve so that's actually collecting and flowing to the patient. So we covered quite a bit, and who knew that we could talk so much about aerosolized treatments, but yes, it's possible. And I hope that this has been beneficial to you to help you to optimize your medication delivery to your patients. Over the course of your careers, you're going to be given a lot of treatments. That's our area of expertise, and that's what we're good at. And so give it the best way you can to optimize the most medication to your patient so that we can get them better quicker. It's been a pleasure again to work with you this mod. If you have any issues or questions from this or any other lectures or something from your clinicals, let me know, and I'll be happy to help you. It's been a pleasure working with you. Good luck to you with the rest of your training. Please contact me if there's anything I can do to help you. And you might see me teaching another one of your courses down the road. I do teach some other clinical courses and mechanical ventilation courses as well. So look forward to working with you again if I get the opportunity. And good luck to you all. And make sure you get your DocuSign stuff in sooner than later this week so we don't have any issue down the road with up against submitting grades. So with that, have a great night. Happy Respiratory Care Week. And hopefully you'll see you in another course soon. Good night.